Welcome to the deep dive. Today we're really digging into Lis Franc injuries. This is absolutely vital stuff for orthopedic residents, especially with those postgraduate exit exams looming. And just so you know, our whole discussion today is pulled directly from those fantastic OrthoMade simple notes you can find over at mokyingren.sg. They were put together by Dr. Mok Ying Ren. He's a sports surgeon at National University Hospital in Singapore, finished his FRCS back in 2022. Incredibly helpful resource.
Definitely. And look, this isn't just about passing exams, right? Lis Franc injuries, if you don't manage them well, they can lead to some really significant long-term problems. Think chronic pain, arthritis. It's serious. Part of what makes them tricky is that they can be quite subtle sometimes, but the joint itself, crucial for foot function. Missing one can be, well, potentially devastating for the patient down the line.
That really drives home the importance. Okay, so let's unpack this properly. Starting with the basics. What exactly is the Lis Franc joint and what ligaments are keeping it all together?
Right, so fundamentally, the Lis Franc joint is the tarsometatarsal joint complex. It's where the tarsal bones meet the metatarsals. Now, metatarsals 2 through 5 are held pretty securely by intermetatarsal ligaments. But the really interesting part, anatomically speaking, is the second metatarsal. It sits recessed, sort of wedged into the middle cuneiform. This makes it act like a keystone in an archer. It's the keystone structure holding that transverse arch stable.
Okay, the keystone. So what about the actual Lis Franc ligament itself? What are its parts, and why do we talk about one being most critical and another strongest?
Good question. The Lis Franc ligament proper connects the medial cuneiform to the base of that second metatarsal. It actually has 3 parts: plantar, interosseous, and dorsal. The plantar component on the bottom is generally considered the most critical for stability overall. It really resists the foot splaying out. Then you have the interosseous ligament, deep between the bones, that one's the strongest physically. It provides real heavy-duty resistance. And the dorsal ligament on top, that's the weakest. And that weakness explains something we see clinically all the time.
Which is
Why these injuries often result in dorsal dislocation. It's simply the path of least resistance when things go wrong.
Got it. Weakest link on top. So thinking about diagnosis is super important for residents. What are the absolute must-know X-ray lines and signs you're looking for?
Okay, imaging. Standard protocol is usually 4 AP views, and definitely get a weight-bearing AP if you can. That's critical, plus 1 lateral and 1 oblique. On that AP view, there are a few key things. First, the flexine. See that little chip of bone off the second metatarsal base, or maybe the medial cuneiform? That's a huge red flag for a Lis Franc ligament tear. Also, look for any widening of the space between the first and second metatarsals. Even a couple of millimeters difference compared to the other foot can be significant. Then there's the line you trace along the medial border of the second metatarsal. It should line up perfectly with the medial border of the middle cuneiform. If that line is disrupted, something shifted. And don't forget Mill's line. Draw a line down the medial side of the medial cuneiform. It should cut right through the first metatarsal. If the midfoot has shifted laterally, that line won't intersect properly anymore.
Okay, flexine, widening, the second MT line, Mill's line. What about the other views?
Right. On the oblique view, you're checking the alignment between the medial border of the fourth metatarsal and the medial border of the cuboid. Keep an eye on that lateral column alignment. And the lateral view. The classic sign there is dorsal subluxation of the second metatarsal base relative to the cuneiforms. You see that step off, that's a big problem.
Weight-bearing views are key then. Don't miss subtle widening. Okay, let's shift gears to the really dramatic ones, high-energy trauma. How do we classify those, and what's the immediate game plan in the ED?
Yeah, high-energy ones are a different beast. We use the Meyerson classification. Type A is total incongruity. All 5 metatarsals are shifted together, usually laterally. Type D is partial incongruity. So either the medial column empties 1 to 3, or the lateral column empties 4 to 5 is displaced, but not both together. And type C is divergent. That's where the medial and lateral columns actually split apart from each other. You get this big gap. In the ED, acutely, first thing is a back slab for immobilization, pain control. If it's really unstable, open, or lots of swelling, you absolutely need to think about putting on an external fixator for temporary stability. Let the soft tissues calm down. And crucially, after you've got things initially stabilized, get a CT scan. It's not optional. You need it to see the full extent, the comminution, the subtle joint involvement. It's essential for planning surgery.
Absolutely essential. Okay, so CT's done. We're heading to the OR for a bony Lis Franc injury. What's the typical surgical approach, and what's the strategy for putting things back together?
The common approach uses Meyerson's 2 dorsal incisions, one between the first and second metatarsals, the other along the fourth. You need a good skin bridge between them, at least 7 centimeters, to protect the blood supply. This gives you access to both the medial and lateral columns. Now, for bony injuries, the plan is generally fixation, not fusion. And the principle is always fix from medial to lateral. You establish stability medially first.
Medial to lateral. Why start medial?
Because that medial column, especially the first ray, and the Lis Franc joint itself is the foundation. You get that reduced and stable, then build outwards. So, step 1. Stabilize the first metatarsal to the medial cuneiform. You can use a retrograde screw, meaning going from the MT back into the cuneiform, or maybe a small plate. Step 2, the crucial one. Stabilize the medial cuneiform to the second metatarsal base. That's your classic transarticular Lis Franc screw, usually a 3.5 millimeter cortical screw. Then you move laterally. Address the third metatarsal, fixing it to the lateral cuneiform if needed. And for the fourth and fifth metatarsals, the more mobile lateral column, you often just transfix those with K-wires. Hold them in place while things heal, rather than rigid screw fixation.
That makes sense, building from the stable side out. Now, this raises a really practical question one surgeons debate, plate versus screw. Especially for that first TMT joint or bridging combination, what guides that decision?
Yeah, that's a common discussion point.
Yeah.
Theoretically, a plate has an advantage because it sits on the bone. It doesn't have to go through the joint surface like a screw does. So less potential joint damage. However, Frank Alberta and his group did a key study. They looked at biomechanics and found actually no significant difference in stability between a dorsal plate and a transarticular screw. They also pointed out that the actual joint surface damage from a 3.5 millimeter screw is pretty minimal, like 2–4%, not a huge amount.
So the joint damage argument isn't maybe as strong as we thought.
Potentially not the deciding factor in many cases. So the choice often comes down to comminution. Are there lots of little fragments? If there is significant comminution, a plate might be better. It can act like a buttress, span the fragments. If there's no comminution, a screw is often simpler, smaller footprint, perfectly good option. And just briefly, other things are out there too. Suture buttons, like the tightrope system, they exist, but maybe have limitations controlling rotation. And people are looking at bioabsorbable magnesium screws too to avoid needing removal later. Still evolving though.
Okay, useful context. Now let's dive into probably the biggest controversy, the one that always comes up. Should we fuse or fix a Lis Franc injury? What's the evidence say, and what's the thinking behind the preference noted in the Ortho Made Simple materials for fusion in some cases?
Right. This is the hot topic. ORIF versus primary fusion. And honestly, there's still no universal consensus, especially for the purely ligamentous injuries. But there are some really important studies to know. Coetzee's 2006 randomized controlled trial in JBJS is a big one. They looked specifically at 41 patients with ligamentous Lis Franc injuries. They compared ORIF directly against primary fusion, and the finding. At 2 years, the fusion group actually had better outcomes. Higher return to pre-injury activities, 92% versus only 65% for ORIF.
Wow, that's a big difference.
It is, and maybe even more striking, about 25%, a quarter of the ORIF patients ended up needing a later fusion anyway because they developed painful arthritis, so a second surgery.
Ouch. But hasn't other research shown maybe less of a difference?
Correct. A systematic review by Smith and colleagues in 2015 looked at all the data and found, overall, no significant difference in outcomes between ORIF and fusion. They did note, though, that hardware removal was more common after ORIF, so the evidence is a bit mixed. But the practice preference you see in the notes, in my practice, I will opt to fuse ligamentous Lis Franc injuries, reflects a growing trend based on that risk of post-traumatic OA. The rationale, and this is key for residents to grasp, is that purely ligamentous injuries, especially involving that critical Lis Franc ligament complex, have a high chance of not healing well enough. The ligaments just don't have great healing potential. This can lead to ongoing instability, pain, and eventually arthritis. Fusion sacrifices some midfoot motion, yes, but it aims for a stable, pain-free, predictable outcome long-term, potentially avoiding that second surgery. It's often seen as the more definitive treatment for purely ligamentous tears.
That really clarifies the thinking behind choosing fusion for ligamentous injuries, prioritizing long-term stability over preserving potentially unstable motion. Okay, so after surgery, what's the typical rehab protocol? And what's the deal with hardware removal? Is it always necessary?
Post-op rehab is pretty standard initially. Strict non-weight bearing for 6 weeks. That's crucial to let everything start healing without stress.
Hardware removal.
Well, like the fusion debate, there's no absolute consensus globally. It's not always done routinely everywhere. However, if fixation was done with screws, especially that main Lis Franc screw crossing the joint, the plan outlined in the notes is often to remove the hardware around 4 to 6 months post-op. The idea is once bony healing is solid, taking the screws out might reduce any irritation from the hardware and potentially allow a bit more physiological motion, particularly across the TMT joints. Before removal, patients can often start low-impact stuff like swimming or cycling, assuming things are healing well.
Makes sense. And one last point on diagnosis that seems a bit murky sometimes, that flex sign we talked about. Is it technically a bony injury or is it considered ligamentous? Why does that distinction even matter?
Ah, yes, the flex sign paradox. It's a great question and definitely controversial, a good exam point. Technically, it is a fracture, right? A small piece of bone pulled off. But importantly, many consider injuries presenting with just a flex sign, like Coetzee did in his original paper, to be functionally ligamentous injuries. The key takeaway for you is that the flex sign indicates the primary pathology is the failure of the ligament. The bone chip is just evidence of that ligament tearing off its attachment. And why it matters goes back to our fusion discussion. If you see a flex sign, you should immediately think major ligament disruption, which might push you more towards considering a primary fusion due to the high risk of instability and future arthritis if you just rely on ligament healing.
Okay, so flex sign, think underlying ligament failure. Got it. Now let's switch from high-energy trauma to the sports world. How do we classify and manage those lower energy, maybe more isolated Lis Franc injuries you might see in athletes?
Right. For the lower energy, often sports-related injuries, the Nunley and Vertula classification is really useful. It helps guide treatment based on stability. It has 3 stages. Stage 1 is basically an undisplaced sprain, maybe just tenderness. X-rays might look normal or show very minimal widening, perhaps only on weight-bearing views. No displacement. Stage 2 is where you see definite widening between the first and second metatarsals, more than 2 millimeters on the AP view, but crucially no dorsal subluxation on the lateral view. So it's unstable, but not grossly dislocated upwards. And stage 3 is the clearly unstable one where you do see dorsal subluxation on the lateral X-ray. The joint is shifted upwards.
And how does that staging affect management?
It's pretty clear-cut based on their work. Stage 1 injuries, being stable and undisplaced, can usually be managed conservatively. Non-weight-bearing in a boot or cast for about 6 weeks, then gradual rehab. That's your chance to avoid surgery. But for stage 2 or stage 3, any injury with that significant diastasis or any dorsal subluxation surgery is indicated. These are unstable injuries. Even if it just looks like a little bit of widening in stage 2, it represents a failure of the key stabilizing structures. They need anatomical reduction and stabilization, usually fixation, to prevent long-term problems like pain, deformity, and arthritis. You can't just ignore that instability.
Don't underestimate that stage 2 widening. Okay, we have covered a ton of ground today. The anatomy, the imaging, high energy versus sports injuries, the fixation versus fusion debate, all drawing from those excellent OrthoMade simple notes on mokyingren.sg. As we wrap up, what do you think is the absolute most critical take-home message for residents listening?
I think if I had to pick one thing, it's maintaining a very high index of suspicion. These injuries are missed too often. So, meticulous clinical exam, insisting on good quality imaging, including weight-bearing views when needed, and really scrutinizing for those subtle signs. Beyond just spotting it, though, is understanding the why. Why are we fixing medial to lateral? Why might we choose fusion for a ligamentous injury? Understanding the controversies like fix versus fuse or the flex sign debate isn't just for exams, it's about being able to think critically and justify your treatment plan. Moving beyond just what to do to truly understanding why.
Understanding the why behind the what.
Exactly. And connecting it to the bigger picture, it all comes back to making informed decisions tailored to that specific patient and their injury pattern to give them the best chance of a good long-term outcome.
Absolutely. And maybe a final thought for our listeners to chew on. Where might this field be heading? What questions should they keep asking? Perhaps thinking about how new imaging or even biologic techniques might change how we approach these challenging injuries in the future. Lots to still explore. Well, thank you so much for joining us on this deep dive into Lis Franc injuries. We really hope this discussion, grounded in the OrthoMade simple notes from mokyingren.sg, has been genuinely helpful for your learning and exam prep.
It's been a pleasure. And as you continue on your path in orthopedics, remember this piece of wisdom from Proverbs chapter 11, verse 12. Whoever belittles his neighbor lacks sense, but a man of understanding remains silent. Keep that spirit of learning. Keep growing. Seek understanding diligently, but also with humility.
Excellent words to end on. Until next time, everyone, keep digging deeper.